welcome everyone who's joining. We'll give it one more minute and then we'll officially go ahead.
Good morning, good afternoon.
Okay, it is 12:02 in Sydney and Melbourne. I would officially like to welcome everyone. It's good morning, good afternoon to those joining from Australia and New Zealand. It is good evening to those joining us from the Northern Hemisphere, namely the United States, and actually good Tuesday evening, whereas it's Wednesday midday here. Welcome to this first, hopefully of many, virtual educational symposium organised by the Australian-New Zealand chapter of the Neonatal Kidney Collaborative. You could have the next slide, please. I would like to start by an acknowledgement of country. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land from which I join this virtual meeting today. I also acknowledge the traditional custodians of the lands where you are all located today. We pay our respects to their elders, past, present, and future, for they hold the memories, traditions, culture, and hopes of Aboriginal and Torres Strait Islander peoples of Australia. In recognition that the NKC ANZ chapter is a binational collaboration, we acknowledge the Maori people as Tangata Whenua and Treaty of Waitangi partners in Aotearoa, New Zealand. My name is Evelyn Staub. I'm the head of Department of Neonatology at Royal North Shore Hospital on the North Shore of Sydney. And online with me also is my co-chair, nephrology co-chair of the Australian-New Zealand chapter of the NKC, Tom Fawkes, sitting in Melbourne, while I'm the neonatal co-chair. We can't miss out on the opportunity to give another plug for the Neonatal Kidney Collaborative and the Australian-New Zealand chapter thereof. The NKC has existed since 2016 and was founded after a gap was found after an NHS symposium in the knowledge and drive in all things neonatal kidneys. And we're proud that we're now 1 year into the first international chapter, the Australian New Zealand chapter, where we have gathered over 30 neonatal and nephrology specialists in Australia and New Zealand to equally drive education, research, and advocacy for the neonatal kidneys. If you go to www.babykidney.org, you'll find a join button for Australian New Zealand peeps, so please feel free to do so and join an awesome bunch of people that are very passionate for the kidneys in neonates. It's now my pleasure to hand over to Dr. Jane McMahon, who's sitting next to Tom in Melbourne. Jane is a neonatal fellow, soon to be consultant at the Royal Children's Hospital in Melbourne, but more importantly, she's the inaugural Australian Six to Crew member, so congratulations to that. And she is going to take it from here together with Tom, introducing a virtual case and then eventually handing over to our speaker for today, Dr. Michelle Starr.
Thanks very much, Evelyn. We thought we'd just start with a case today, a classic kind of neonatal case that might come up in each of our NICUs, just to frame the presentation today. So we're starting with, this is an X24 weeker who's now 42 plus 2 weeks corrected, who's got a consistent blood pressure of 100/70 measured non-invasively. Baby's background is chronic lung disease and has recently come off low flow oxygen. They've got bilateral IVHs with a grade 2 and grade 3 IVH, retinopathy of prematurity, which is not yet required treatment, and they had stage 1 AKI at 28 weeks. They've also got a history of spontaneous intestinal perforation and have had stoma closure. In terms of their current investigations, they've got a creatinine of 14, sodium of 142 with potassium 4.4. They've had an ultrasound, both KUB and Doppler, which has showed echogenic medulla, kidneys on the 5th centile, but no artery stenosis. They've had an echo, which just shows a secundum ASD, TFTs and platelets metanephrines that were normal, and renin-aldosterone ratio that was normal. Some questions around this case.
So what we might do is, if you've got your mobile phone handy, and you can scan the QR code there on the right, we'd love to just get a feel for the audience's level of comfort with that case in particular. We've got just 3 very simple questions to answer. So jump in. If you're neither a nephrologist or a neonatologist, then fantastic. Thank you for coming. You can choose who you want to be for the day. But maybe neonatologist would be better, because we would we can change that to non-neonatologist. We're getting a bit of an even spread here, aren't we? We've got 16, 17 responses. It is a deliberately sort of ambiguous case. It's not a sort of lay down misère, clear case. What we're seeing from the neonatologists here, and we'll give it just another minute. We've got 38 people online. We might have a few groups too. So once we reach an equipoise, we might move on. But it looks like the majority of neonatologists are feeling less confident, whereas the majority of nephrologists are feeling, but not all, are feeling more confident. All right, let's move on to the second question. It should update on your phones automatically. We're interested to know whether your NICU or your hospital, if you're a nephrologist, has a guideline for the management of neonatal hypertension. I'll log in for us too. And that's, yeah, unsurprising, in my opinion. It certainly gives us an opportunity to meet today and to hear from Michelle, and also to do some work. Great, thank you. And last one, do you know where to find blood pressure centiles? And if so, where do you find them? You can see I've been a little bit tongue-in-cheek. Hopefully, again, that will update for you, although mine hasn't. Oh, here we go. You might need to refresh your screen. The 4th option there was a bit tongue-in-cheek, but I can see a few people have gone for it anyway. That's great. I'm glad that no one's put number 3, if it's not too early to disclose that. Okay, wonderful. All right. Well, with all of that, it's great to see that people have got some evidence-based resources that they refer to. We'll see if that aligns with the experts, and we'll move on to introduce our speaker.
So it gives me great pleasure to introduce our guest speaker today, Dr. Michelle Starr. Michelle is an Associate Professor of Pediatrics at Indiana University School of Medicine, with joint appointments in Pediatric Nephrology and Pediatric and Adolescent Comparative Effectiveness Research. She earned her MD from Tufts University School of Medicine, completed Pediatric Residency and Chief Residency, and went on to a Pediatric Nephrology Fellowship at Seattle Children's Hospital, University of Washington School of Medicine. Her research focuses on kidney health in preterm infants, especially addressing acute kidney injury and fluid overload in the neonatal intensive care unit, aiming to improve both short and long-term renal outcomes. She is a board member of the Neonatal Kidney Collaborative and has led the consensus recommendations advocating for the inclusion of kidney health measures in neonatal research and follow-up care guidelines. Welcome, Michelle.
Thanks for having
Michelle,
me.
I'll turn off our sharing here and let you
All right. Can you see my screen and hear me okay? Awesome. Perfect. Well, thank you for the introduction. Thank you for the opportunity. This is wonderful topic, one that is, I'll admit, was not initially kind of what drew me into neonatal nephrology, but has become a kind of a pet passion project. I am happy for this to be as informal as people want. So if people have questions, maybe Tom, Evelyn, or Marissa, I'll put you guys just in charge of like monitoring the chat and letting me know. But I'm happy to stop and answer questions as we go. So I've titled this talk, I saw the thumb, thanks, Tom. All you need to know about hypertension in infants. And so this is a little bit semantics, but I think I have been corrected enough times by my neonatology colleagues to really think about, hypertension outside that first month or 28 days of life as well. So really, I'm going to talk about hypertension while a baby is in the NICU, whether that's during that neonatal time period or that infant time period as well. So let's get started. I don't have any relevant financial disclosures, but I'm going to talk about a lot of stuff that is off-label because pretty much every way of measuring, treating, or evaluating blood pressure in babies is off-label. But I'm going to be as balanced as I possibly can, and I will let you know when there is no evidence, which is most of the things I'm talking about today. My objectives today are to talk about the differential diagnosis or the diagnosis of infantile hypertension. We're going to talk about the common causes of high blood pressure in infants, including kind of understanding presentation and natural history. And then we will talk about directing the management of high blood pressure, so including initial pharmacologic therapy directed at whatever the underlying potential etiology is. So let's get started. So I think the first thing to think about when we're talking about treating an abnormal value is what is normal, when is it normal, and how do we figure out if it's normal? So let's start there. So normal blood pressure in infancy is challenging for a variety of reasons. We know that blood pressure in newborns is dependent on their birth weight, their gestational age, their postmenstrual or postconceptual age, and then a lot of maternal factors as well. But we know early on in life, so within the first couple of days of birth, that birth weight and gestational age are the strongest determinants of blood pressure. And then after you get past those first 5 days of life, the postmenstrual age appears to be the strongest determinant of blood pressure. The data that we have for this is all very old at this point, but I think still holds true. The reality is that the number of babies that are included in the lowest gestational age in these studies was very small. And so I think the margin for error is pretty low at those lower gestational ages. And they all end around 24 or 23 weeks, which is not kind of current practice as well. But the best data we have is from something called the Philadelphia Neonatal BP study, which was a large multi-center study with almost 10,000 infants and over 25,000 blood pressure measurements. And they found this really nice correlation between blood pressure and gestational age, which you can see here as well. I am happy to share these slides. I know we're recording this as well. The QR codes on each slide will take you to the original source article if that is helpful for you as you kind of go back through or look at this. What do we know about blood pressure in postmenstrual age? Oops. Like I said, after day 5, there really seems to be a gradual increase each day in both the systolic and the diastolic, somewhere between, a quarter of a point in terms of systolic each day. And you can see those trends are very similar when we think about what's happening with these babies in their postmenstrual age. We know that the systolic blood pressure rises initially and then seems to stabilize around 44 to 48 weeks, which may be applicable to some of our babies that are staying in the NICU for longer. And that really is irrespective or independent of their gestational age at birth. So really driving home the fact that it is their postmenstrual, their postconceptual age that is driving their blood pressure after a period of time. So what does this look like if you want to put all of that information together? So early on, it's really how old a baby is and their birth weight that drives their blood pressure. And then over time, all of these factors kind of coalesce. And by the time a baby is either corrected to full term or is born at full term, their blood pressures are going to be around the same. So we talked about what's normal. Let's talk about how we measure it and how we truly determine, because we all know that blood pressure in babies is hard. And when I go into the NICU and I tell people how they should be measuring blood pressure, Lots of people laugh at me because it is really hard to do it well. And I recognize as a nephrologist that I am telling people to do things that are sometimes impossible. And this is one of those places where our blood pressure measurement tools are not good. And we need better ways of measuring blood pressure in babies. So this is my unicorns and rainbows ideal way of measuring blood pressure, right? So ideally, you want a baby in a supine position. All of our standard blood pressures in older children and in younger children are based on upper extremity readings. So ideally, you want an upper extremity reading as long as you can get a cuff on an upper extremity. Calf readings are about the same as a brachial reading for the first 6 months of life, and then there's a discrepancy. So if you have a baby where you cannot use an upper, a lower, if the baby is laying flat, is reasonable as well. And like for some of our kids with either thrombus or lines, really, we can't get to an upper extremity. You want to use a consistent extremity for all readings, so that way you are comparing apples to apples, and you want to make sure that the extremity, the cuff, and then the infant state is also documented when you're trying to measure blood pressure, because that really allows you to figure out what's going on later. So there's several different ways to measure blood pressure. The first, does someone have a question? Okay. So there's several different ways to measure blood pressure. One, which is the most accurate, would be using an indwelling arterial catheter. That can either be a radial or an umbilical. You can use a Doppler. So remember, Dopplers measure systolic only, and it's probably the least expensive and the easiest method. Or you can use an oscillometric method, which is often referred to as a Dynamap or an oscillometric cuff. I want to talk a little bit more about oscillometric blood pressure cuffs and what they truly measure. And this is where I get to nephrology nerd out a little bit on you, so I apologize. But there are inherent inaccuracies here, and we really need to think about the importance of cuff size if you're using oscillometric. So how does an oscillometric blood pressure machine actually work? So when you have a heartbeat, right? When you have something that is generating pressure in your vasculature, which is what blood pressure is, the arterial wall oscillates. Blood flows in a pulsatile fashion. The arterial wall oscillates with that pulsatile flow. The oscillation itself, so that kind of amplitude of the oscillation is transmitted to the cuff. And the mean arterial pressure, or the MAP, is the point where there is the greatest average oscillations. And it's important to remember that with oscillometric blood pressure cuffs, the MAP is the only thing that is measured. So your MAP value is what is measured, and your systolic and your diastolic are estimated values based on your MAP. And every different cuff has a slightly different proprietary formula that they use to calculate the systolic and the diastolic. It's just important to remember that when we are truly looking at what's measured, MAP is the only piece of your blood pressure reading when you use an oscillometric cuff that is measured. So this is important when we think about what are we truly measuring, what are we evaluating, what are we kind of basing our diagnoses on. So this is I kind of covered this a little bit, but the problems with oscillometric, right? It's easier. It's what most of us use, or what we certainly use here, mostly in the States. The formulas are all proprietary, so we don't really know how they're calculating systolic and diastolic. It takes a little while to get a result. And then there are big differences depending on the activity of the baby, right? We know if a baby is crying or struggling or breathing hard, we can see swings of somewhere between 5 and 10 millimeters of mercury, which can make a really significant difference when we think about what makes 90th, 95th, or 99th percentile. So it's helpful to follow trends. Ideally, you want to be using the same extremity if you're going to be using oscillometrics over time. So how does it compare to what I would consider probably the gold standard, which is an intra-arterial blood pressure? So oscillometric correlates well in healthy babies. The problem is you probably don't really have an intra-arterial blood pressure measurement in a healthy newborn baby. But in ill babies, the correlation is not really good. So this was a really nice study. It's a little bit older at this point, but I think the message really holds, where they looked at paired invasive and oscillometric measurements, and the oscillometric method overestimated MAP, SBP, and DBP in most babies. And at the lowest blood pressure, so when a baby was hypotensive based on interarterial, that's when the difference was the biggest, which is really important, right? Opposite end of what we're talking about today, but really a lot of this is about getting a value that you can trust as well. So if you have a sick baby, Dopplers or oscillometric devices are probably not the best, especially if you are worried about low blood pressure. The other point I want to make is that cuff size and proper cuff size is really important. The question Tom had about NICU guidelines for hypertension, a major part of our guideline is how to measure blood pressure. So how to find the right cuff size, how to measure for cuff size, how to take blood pressure, how to document blood pressure. And we find if we are all speaking the same language, documenting, recording, and assessing blood pressure the same way, it makes our conversations and our consultations for infant hypertension a lot more productive and fruitful. So ideally, you want to use a BP cuff with a width closest to the arm circumference ratio of about 0.5 for all non-invasive measurements. And so that's what it looks like. You measure across. You want the width of the cuff here to be about 50% of the arm. So this is a table from a really nice review paper, which is also old, but talks about a nurse developed protocol for high blood pressure or blood pressure management. So this is their standardized protocol. We have integrated something very similar into our clinical practice guideline for neonatal hypertension. But the standards include kind of how you measure, when you measure, position. And then, ideally you want to get several blood pressure readings at intervals so that you have several points of data to assess as well. And then here's a nice graph, which kind of shows the thing that I was talking about, which is the difference between states. So you can see the infant state down the bottom. Systolic is in the darker bar, and then diastolic is in the lighter gray bar. And you can see that it doesn't look as dramatic in the way this figure is drawn, but you can see there's probably a difference between about 65, 66, and about 75 in between a baby that is in deep sleep and active alert or crying. So there can be a pretty significant difference. And when we're thinking about whether a baby is above a threshold or a percentile, that certainly can make a difference as well. So that's kind of what I wanted to cover in terms of how we measure and what do we know about normal blood pressure. Now I'm going to turn a little bit to hypertension. Before I do, I'll pause. Are there any questions that I can answer? All right, let's talk about hypertension, which is why you guys are all here, hopefully. All right, so I kind of break this when I think about high blood pressure in babies into 3 periods of high risk. So the neonatologists in the call probably don't care so much about this big baby because they look way too old to be in the NICU. But I think about neonatal onset, so really that first week of life, infancy, so about the time our babies are starting to get ready to go home and their hypertension is stopping them from going home, which is my favorite Friday afternoon consult, and then childhood when they come back to see us. So what do we know about these 3 periods of highest risk? So we know based on kind of available data, which is limited, unfortunately, that there is a broad range of the number of babies who have early hypertension. So somewhere between 0.2 and 3%. This is like early within that first week, average onset of 5 to 7 days. This is things that usually have a preceding event. So something like AKI or an UMBI line or an underlying diagnosis. And we'll talk about some of these later. We then have this period of infancy right around the baby's time, either around the time babies are re-reaching term and getting ready to go home, or when they're seen in NICU follow-up. We know that 1 to 5% of infants seen in NICU follow-up will have high blood pressure, and that's asterisks of those who have blood pressures checked, which is probably not enough of them. That is my slightly, that's just commentary. And then we know that about 40% of babies with BPD have hypertension as well. And the average onset of those is about 4 months. So about that time they're getting ready to go home or right after they go home. The American Academy of Pediatrics recommends blood pressure checks at all visits for babies who are discharged from the NICU. We'll talk a little bit about why that's a tricky thing to recommend and some of the limitations there, but I just want to bold that because That is something that is kind of current adopted guidelines. And then, we don't really know much about babies after they go home, especially premature babies, and we're trying to close some of those gaps with Awaken too. So I saw someone's having a hard time. Am I not talking loud enough? Are you guys having a hard time hearing me?
No, we can hear you fine,
Okay.
Michelle.
Okay.
I think
Okay.
Amelia's just struggling on her end.
Okay, sounds good. I just wanted to make sure it wasn't me.
Thank you.
I'm also doing I'm not talking super loud because there are 3 children sleeping upstairs.
No, you're
Hopefully.
loud and clear. Yeah, you're all
Okay,
good.
sounds good. Okay,
And if everyone could just mute themselves as well, that would be great.
perfect. So what do we know about this group of babies, right? These older kids, right? So neonatologists, we're making you care about these babies after they go home as well, just for a minute, I promise. So what do we know about babies' kidney outcomes after they go home? So this is a really outstanding paper led by Sangeeta Hingorani and Dave Ashkenazi, among others, looking at premature babies, so LGANs less than 28 weeks. This was part of the Peanut study. They then did the Repaired trial, which really looked at this group of babies. And what did they find? So they found that of babies, all comers, when they looked at 2-year kidney outcomes. We can talk about CKD. We can talk about CKD at another point. I want to draw your attention over here to the blood pressures. So 22% of these children, so less than 28 weekers, had blood pressure systolic greater than the 90th percentile, and 44% of them, almost half, had diastolics greater than the 90th percentile when they had their 2-year follow-up. That's a really high number. And when you look down here at what the systolics were associated with, so increased blood pressure at 2 years was associated with indomethacin and black race, and diastolic was associated with male sex, severe AKI during the neonatal time period, and endomethacin use. We can have a long conversation about whether these risk factors are truly risk factors, whether they are surrogates, or whether they are markers of PDA or BPD or the severity of the critical illness. It's important to note that AKI really only pops up here in terms of diastolic risk, and it's only severe AKI, but all of these babies. So I think the take-home message is if you're less than 28 weeks, you are at high risk of hypertension or elevated blood pressures 2 years after you leave the NICU. All right, so we have really been able to fill in this last little bit, right? So we now know, because of this great article, that almost half of babies who are born less than 28 weeks have diastolic hypertension at 2 years. And this really is something that we as pediatricians need to be watching for in these babies. All right, so I've talked about epidemiology a little bit. Let's talk about how we diagnose hypertension in infants. So our usual definition of childhood hypertension is that if you have hypertension, if your blood pressure is greater than the 95th percentile for age, gender, and height on greater than 3 occasions. How do we figure that out in a premature baby, right? Like, is the right answer your mean plus 2 standard deviations, 95th percentile, like we do with childhood, 99th? There's not a great answer. The best answers we have come from the Flynn article, which is the clinical practice guideline. And really, you need to think about standard tables or graphs for blood pressure by postmenstrual age. Remember, we talked about after that first 5 days, postmenstrual or postconceptual age is really what's going to drive your true blood pressure. So these are the normative tables that I think many of you may be familiar with from this really outstanding article by by Janice Dion and colleagues. It is an older article. I think it is still the absolute gold standard in terms of thinking about blood pressure. This is a reference table of estimated blood pressure values after 2 weeks of age in infants based on their postmenstrual age. They give MAP values to enable you to really think about perfusion pressure. But I think that especially if you are in a unit that is measuring oscillometric, using MAPs makes the most sense because that is the value that you are measuring. So I would suggest thinking about using MAPs when you're trying to figure out diagnosis of hypertension if you are measuring using an oscillometric cuff. So I have simplified this table for our group because I think this table is from, the oldest postmenstrual age It's not how my brain works. So I've reorganized this table, and this is just maps. So this is the table that we have that we use to kind of figure out, is a baby kind of in that 99th percentile that we really should be thinking about consulting nephrology. So when we think about our clinical practice guideline for hypertension in the NICU, this is what we use for kind of our first blush. Like, do we need to be thinking about a hypertension workup for these babies? So based on the Dion data, the clinical practice guidelines said it's reasonable to use that table in the assessment of blood pressures in infancy, but they did not have a strict definition of hypertension. But I would say if your MAP values are consistently greater than 95th percentile, I would suggest doing an evaluation for elevated blood pressure, especially if it's sustained or if they're having elevated blood pressures with symptoms such as heart failure or seizures, which suggest organ dysfunction. So we've talked about how you diagnose. What are you going to do to work up and manage these babies? So every review article, whether it's the Dion article or more recent ones, when you think about neonatal hypertension, you have a very broad differential diagnosis, which can be divided into kind of groups of things. We will come back to this and we will talk about the most common things, but I think it's always nice to just see the list, right? On the left side are more renal specific causes, so including renal vascular and parenchymal. And then we have a whole host of other organ systems that can cause elevated blood pressures as well. So what are you going to do for that baby that we talked about, right? So the case that we presented, that was presented at the beginning, a lot of this workup was already done. So the first is to really think about your history. So these are kind of the elements you're going to want to drill down on. You're going to think about prenatal exposures and maternal conditions, including diabetes and maternal hypertension. You'll want to think about maternal medications and then the labor, delivery, and birth course, right? Thinking specifically about APGAR scores and any concerns for HIE or other kind of like early perturbations that may have caused the baby to be at risk. You really want to think about their other illnesses when we think about our differential diagnosis, and then lines. So thinking about their line history, their PICC line history, when things were placed, when they were removed, and kind of the correlation between that and their blood pressure, and then medication. So lines and medications are the two that I think usually are the hardest to suss out in kind of looking through the chart, but can usually be the highest yield. Physical examination should include a four-extremity blood pressure to make sure we're looking for cardiac causes of hypertension. You also don't want to miss if you have a really large gradient between your upper and lower extremities, or you have differences in your pulses. You want to look for dysmorphic features, which sometimes can give you a clue, especially if you are taking care of a patient who has a board question. You want to look for or listen for heart murmurs, feel for flank masses or abdominal masses, and take a look at the external genitalia, which may give you a clue if there is an endocrinologic cause of your hypertension. Routine studies really depend on what you're thinking in terms of your differential when this baby is presenting, but our usual kind of screen, and this does not necessarily mean all these things need to be gotten again if they have been gotten in the recent past, but including urinalysis, a CBC and a platelet count, particularly if this is an early onset high blood pressure. And so we'll talk about why that is. Electrolytes, including albumin and creatinine, because I can never help myself. A calcium, if you are worried about some of the syndromic causes of hypertension, a chest x-ray, and potentially a renal bladder ultrasound. Additional studies really depend on the patient, but here are some of the things that I will sometimes consider, depending on the story and depending on the infant in front of me. I would say very rarely are these things that I am doing, but sometimes can be helpful depending on the situation. So in terms of general treatment principles, and then what we're going to do for about 10-15 minutes is just dig into individual causes and how I treat them and how I manage them individually, because I think to give a broad, like, treat every baby with hypertension with X med is, doesn't really pay attention to the underlying pathophysiology. So we're going to go kind of thing by thing. But in terms of general principles, Really, most of the time in the neonatal hypertension world, you do not need to move fast. You really want to confirm the accuracy and consistency of your blood pressure readings. If there is a drug that you think is possibly causing this, or if you think fluid overload or volume overload is contributing, or if pain is contributing, you want to deal with those things first. And then really, if it is a critically ill or symptomatic infant, right, those are the ones that you treat, and you treat with a drip, and you treat them very quickly. But most of the time we're talking about this is a chronic infant with mild to moderate elevated blood pressures. And so you're going to be watching the blood pressure for a day or two before you start treating. In terms of agent, really what you choose, how you give it to the baby depends on both the severity, right? So if this is malignant hypertension, you're going to be treating with an infusion because you don't want to lower the blood pressure too fast or too far. But if a baby is tolerating enterals, you're going to want to be able to use that if you can. So my general approach after I feel like the blood pressure is truly elevated, I feel confident that this baby has hypertension, I kind of ask myself three questions. So, how likely is it that this is real? How likely is it to be persistent? And what do we know about the natural history of their hypertension? And so I kind of use the stoplight sort of approach. Green is okay, like this is real. We should probably start therapy now. Yellow is caution, right? Maybe we should consider it, but maybe we're going to wait a little bit or change something or see what happens before we do it. And red is no, let's just not start it. Let's see what happens. So let's talk about why I am a little bit hesitant to start medications, particularly as we're approaching discharge for babies. So what I think it's important to recognize that there are drawbacks to antihypertensive therapies. So one of the things is that if you send a baby home on a medication, you're going to need to check their blood pressure. And for many pediatricians, checking blood pressure on babies is just not something that they either have the equipment or the ability to do. It may mean sending family home with a cuff and anxiety about checking blood pressures and reporting blood pressures and worrying about blood pressures. It means extra clinic visits. It means an extra doctor. It means seeing a nephrologist or someone who is going to monitor and titrate their blood pressure medication. There are additional issues with formulation and getting medication into a form that a baby can take. And like I said, hypertension is really anxiety provoking for families. And so sending them home with a diagnosis of hypertension and a medication and a need to check blood pressures can be very anxiety provoking for families. And then for babies that have hypertension, we often have to adjust the doses frequently as they grow. And so that certainly can be an iterative process. Now, these are never reasons not to start medication in the right baby who needs it, but I think it's just part of my calculus when I'm starting a baby or thinking about starting a baby on antihypertensive therapy. So my initial approach is to start with a calcium channel blocker. So unless there's a strong indication for another class of therapy, and then the usual question is, do we start a short acting, so something like isradipine versus a long acting amlodipine? I usually will just start with a daily chronic medication, but some of my colleagues will start with isradipine and then transition over to amlodipine. I usually start at the lower end of the dose range, monitor until it's steady state, so 2 to 3 days, and then we'll increase. And I like to increase the dose of one agent until I am maximized, and then I add a second agent as opposed to going up on two at the same time. So I do want to say a word about ACE inhibitors because I feel like this is something that people have strong feelings on both sides about. So we know that the RAS system, so the renin-angiotensin system, is crucial to normal renal development, and it's important for glomerulogenesis both prenatally but also postnatally in some of these babies in the NICU. And ACEs can be very potent in infants due to the activity of the RAS system. We know that exposure to the immature kidney to ACE inhibition may impair the completion of normal development, and it has been shown to cause histopathologic lesions. So my usual approach is to avoid ACE inhibitors in neonates until they are corrected to 44 weeks. Now, there are a couple of situations where I actually will preferentially reach for an ACE, so we'll talk about those specifically as well. Perfect. Thanks, Tom. All right, so I'm going to talk about a couple of specific diagnoses. I'm going to roll through these pretty quick, but I think it's helpful to not just use a one-size-fits-all approach for hypertension because the epidemiology, natural history, and treatment can differ a little bit. So we're going to use this kind of stoplight approach throughout because I like it and I find it helpful. I hope you do too. So when we think back to our differential diagnosis, so remember, we're going to categorize things into green, start therapy right away, yellow, think about therapy, and red, maybe hold off. And so we're going to talk about some of these. I have highlighted and color coded. After I did this, someone pointed out that these are real bad colors to use for someone who is colorblind. So I apologize if that is you, and I will do better next time. So sorry about that. So let's talk about, we're going to talk from most common to least common. So hopefully your brains are focused for the first couple of slides. We're going to talk about what I just call NICU hypertension. NICU hypertension is hypertension without another source, right? We can call it infantile hypertension, neonatal hypertension. I call it NICU hypertension because that's who calls me. So 50% of hypertension diagnoses in the NICU have no identifiable cause. This is often when babies are kind of close to NICU discharge. And the thought is that this is potentially due to abnormal maturation in the RAS system. But this usually goes away. So these are babies without BPD, without other kind of comorbidities who are starting to approach discharge, have mild to moderate elevation in blood pressures that are not anything really to write home around. So these are babies where I try and not treat unless their blood pressures are persistently elevated. If you are going to go ahead and treat them, I usually recommend starting with a calcium channel blocker, starting at the lower end of range, and then usually increasing until you get to a maximum. Most of these babies only need mild to moderate dose of calcium channel blockade before their blood pressure is well controlled. The other common thing that we'll see is BPD-associated hypertension. So we know that somewhere approaching 50% of babies with BPD will have hypertension. None of our studies are designed to tell us whether this is correlative or causative, but I would say the classic presentation is a baby with kind of grade 2, grade 3 BPD who is starting to get back to corrected, for full term, right around 36 weeks, 36, 37 weeks, and they are diagnosed with hypertension. This hypertension is usually more difficult to treat than the run-of-the-mill NICU hypertension. We used to think that this was a high renin state, but there's now new studies that really suggest that this is an abnormal or a low renin state. There's some interesting literature about whether BPD is truly, whether this is just a surrogate risk factor, whether hypoxemia or kind of chronic low-level hypoxemia somehow plays a role here. There's also some work done by some folks at OHSU, which suggests that phthalates, which are sometimes in the tubing of a lot of these, things that babies get exposed to, may be a factor as well. This hypertension tends to persist past the NICU. So this hypertension usually ends up getting treated. So these are babies that I am a little bit more ready to treat. They also are going to be following up with our pulmonology colleagues who have gotten good at checking blood pressures because we have forced them to. In terms of management approaches. So diuretics work really well for these babies. These babies are often already on diuretics for their pulmonary disease as well. We have started treating these babies with spironolactone as our initial therapy. That's based on some data about that renin-aldosterone. So we actually get renin-aldo in these babies, and if they are abnormal, so if they are very low, we will add spironolactone as our kind of second line after a diuretic, and that has worked really well in our experience. So we kind of talked about that. I have more information about that in this review paper that is QR coded up there as well, and happy to talk about that as well. So going from most common to least common. So one of the things, especially if you are a board question, to think about in terms of a cause of hypertension is renal vein thrombosis. So hypertension is common in babies with renal vein thrombosis. So of babies with renal vein thrombosis, about 40% have hypertension, but it's an uncommon cause of neonatal hypertension because it's rare. This classically presents with an abdominal mass, hematuria, and potentially thrombocytopenia, much more than hypertension. And if it's going to be unilateral, left side is much more common than right side. The etiology of renal vein thrombosis hypertension is due to renovascular hypertension and RAS system activation. I will note that the epi data here is really out of date because we used to not anticoagulate these babies, and now we do. There is a big pediatric neonatal research, or PNRC, which is the Nephrology Research Consortium here in the States, that is doing another study trying to get better epi data. So I'm hopeful that that will update our understanding here about how this kind of looks. So natural history. So this is what I mean. Like, this data probably is out of date. I present it with a huge caveat there. So we know in babies that have renal vein thrombosis, about half end up getting an acquired solitary kidney. So that kidney, which is thrombosed, usually does not regain function. This is without anticoagulation. Hypertension usually is there, but gets better. But these kids are actually at higher risk of CKD and decreased GFR during childhood. So even if they don't truly need management of their high blood pressure, I continue to follow them in a nephrology clinic because I'm worried more about their kidney function more than anything else. So if you're going to treat these babies, like I said, we are now anticoagulating most of these babies based on new data and evidence. If they need antihypertensive therapy, this is a class of babies where ACE inhibitors may be reasonable, especially if that kidney already looks non-functional. And then really they should be following up with pediatric nephrology given their risk of CKD. So we think about big vessel, so renal vein thrombosis. Then we think about teeny tiny little thrombus. So I call this catheter-related hypertension. Probably very common, probably a big contributor to that neonatal or NICU hypertension as well. So we know that thrombus forms in about a quarter of UACs that are placed, but we really can never diagnose catheter-related hypertension. So the epidemiology is very unclear. These babies have hypertension, but they will normally have normal renal vascular imaging. But the thought is that the etiology for this is due to endothelial disruption when you either place or remove the line, and then secondary activation of the RAS system. This usually gets better. It's usually a short-term phenomenon in either the period of catheter placement or removal, but sometimes can follow up by 1 to 2 weeks. So these are babies where if I think it's related to the catheter, either removal or placement, I'm going to watch them if I can without treatment. But you could consider therapy with a calcium channel blocker. I do want to say a word about the heart because it's usually not the kidney's fault. Sometimes it's the heart's fault too. So it's important to remember that babies with coarct have a very high risk of hypertension, not necessarily acutely in the NICU, but even after their surgical repair, they have a 30% risk of hypertension during childhood. These kids, this is much more for the nephrologists on the call, just because I find this fascinating. These babies often will develop hypertension that is nocturnal or masked. And so there is now growing consensus of recommendation in the congenital heart disease community to ABPM babies with coarctation to try and pick up their hypertension. So this has to do with the way the aortic arch is formed and innate abnormalities of the vascular wall. So I think it's very fascinating, but usually these babies continue to have persistent hypertension even past their NICU and their infant period. So these are babies who really need good blood pressure monitoring. If they are hypertensive, these are kids where an ACE inhibitor for renal protection is probably reasonable. And then they are at really high risk of hypertension during childhood. So yes, you're going to want to treat them, but yes, you're also going to want to follow them as well. So I said it's mostly the heart's fault. Sometimes it's the kidney's fault. So I do want to say a word about ARPKD because this is one of the situations where I actually reach for RAS inhibition pretty quickly. Hypertension is a common presenting symptom in neonates who have ADPKD. So remember, autosomal dominant polycystic kidney disease usually presents later in life. In babies who have ADPKD, so severe disease, hypertension is one of the common presenting signs. But it's also common in babies with ARPKD as well. So their presentation really depends on their etiology, and there's a wide variability in when babies are going to present if they have ARPKD. So ARPKD-related hypertension does not get better. We know that their need for neonatal ventilation is the best predictor of their long-term outcome and their kidney outcomes, but their CKD is common and it's progressive. So these babies really have hypertension that is difficult to treat and needs to be treated. Often these babies need either an infusion, and these are babies where I will ACE them because of their large kidney size as well. And so sometimes ACEs can really help us as well. Sometimes you actually have to take these babies' kidneys out or one of their kidneys out if they really have severe hypertension. And then there's a bunch of other congenital abnormalities or K-cut, including multicystic dysplastic, dysplasia, hypoplasia, or some of these urology, more obstructive pictures. So in kids with other congenital abnormalities, about 10% have hypertension, and it really depends on the etiology and the severity. This is usually due to alterations in the RAS system and can be due to direct compression of the vasculature. These usually get better as long as it is not multicystic dysplastic related. So if you need to treat these are ones where really surgical management, if they have an obstruction, is going to be the best. Chronic management, really, you're going to do a calcium channel blocker. Sometimes if it's a kid with multicystic dysplastic kidney where that kidney is not shrinking down and they're having severe hypertension, sometimes you do need to think about nephrectomy to really control that RAS activation. And then I think this is my last one to talk about is tumors, right? So we have all been consulted. Usually it's not the NICU, but sometimes it is in the NICU for babies who have tumors as a cause of their hypertension. So up to 90% of common pediatric infantile intra-abdominal tumors, so Wilms neuroblastoma, present with hypertension. And infants rarely present with PHEOs or choriangiomas, but of those, 100% will have hypertension. This is usually either they get diagnosed with a tumor and then they have high blood pressure, or they have hypertension that leads to the diagnosis of the tumor. So sometimes it's chicken, sometimes it's egg. The etiology is usually due to compression of the renal vasculature, and sometimes the tumor itself will make vasoactive substances. Usually this gets better after management of whatever the cause is. In Wilms, there is a higher risk of hypertension after surgery, both because of the solitary kidney, but also something beyond that as well. So this depends really on what the tumor is and the surgical plan. Sometimes you need to acutely manage these kids, particularly if it is a catecholamine secreting tumor. You want to get that kind of cause of their hypertension out and then readdress afterwards to think about chronic therapy. Remember, if this is a PHEO, this is not a neonatal problem. Often, usually ever, I think. I don't think I've ever seen a PHEO in a kid in the NICU. Maybe like an 18-month-old, I think is my youngest PHEO, should be managed with alpha blockade and then beta blockade afterwards. Okay. So in the last like 2 minutes, and then I'm going to open it up for questions, I just want to talk broadly about discharging babies and thinking about hypertension management as we transition babies to outpatient. We've talked about a lot of these principles, so it's just a really brief review to wrap it up and bring it back home. So remember, what do we know about infantile hypertension? Most babies with hypertension that is diagnosed and started treatment in the NICU, it gets better. Most babies are off hypertensive medicines by 2 years of age, and only 15% of babies with hypertension as infants are still on medicines at 6 months old. We don't really know after they get off meds what happens. Do they go back on? Do they have higher risk during childhood or adulthood? We don't really know, and we really need better data long term. But this is a really nice figure looking at blood pressure, medication burden after discharge. So you can see that as babies get further out from the NICU, their number of antihypertensives decreases quite dramatically, and very few of them are still on meds at 2 years of age. It's also really hard to measure blood pressure after babies go home. Remember, this gets to the point I was talking about. So this is a really nice study which was done at CHOP and looked at basically which babies that should have had blood pressure measured actually did. So they found that of the blood pressure, or of the babies who should have had post-NICU discharge blood pressures, only 38% had a blood pressure measurement done. And that primary care had 41% of the overall visits for those patients, but only measured 4% of the total measurements. And surgical specialties didn't really check blood pressures at all, but cardiology and nephrology did. And that is because our tools are not good here. We don't have great cuffs. People don't feel comfortable with the cuffs. They don't have small cuffs, and our blood pressure machines are not great. All right. So with that, I will stop. In terms of conclusions, really, overall arching goals for this talk. So, and things that I think you should hopefully take home, check blood pressure in all infants who go home from the NICU. If you are part of a NICU or a neonatal nephrology program, think about standardizing how you measure and evaluate elevated blood pressure in infants, which would include method of measurement, location, and state, and a kind of an initial approach. Target your blood pressure evaluation towards likely causes, thinking about workup in babies depending on their cause. I would urge you to consider thinking about your BPD babies, particularly thinking about spironolactone in those, and thinking about etiology and treating those differently. Calcium channel blockers are my go-to, unless there's some good reason to do something different. And then really think about a tiered approach and whether you truly need to start blood pressure meds, and if you are, how you're going to get a baby off of them. So with that, I will stop here. This is a slide which has the evaluation, so that you can let me know how I can give this talk better in the future, besides not using colorblind colors, and so we can do these better in the future as well. So with that, I will stop. I will keep this up. I will not unshare my screen yet, but I'm happy to take any questions, and thank you very much for letting me talk about this.
Thank you so much, Michelle. That was absolutely excellent. We're just going to go with some questions now. If you have any questions, there's quite a few people online, so if you put them in the chat, we can read them out. I think Tom had a question to start just while people have a think about what they'd like and pop them in the chat.
Yeah, thanks so much, Michelle. Really appreciate it, and I want to call out particularly that the hours in the US are not particularly sociable at the moment. So you've very capably managed bedtime and presentations, and we're very grateful for that. I had a question around the sort of the definition of the neonatal normal range, because we define it, according to above the 95th centile, which is somewhat arbitrary. And that is probably extrapolated, like many things are, from adult practice, where we know that sustained blood pressure above this level, or, there's definitions for hypertensive emergency and hypertensive urgency to avoid CNS problems like, posterior reversible encephalopathy syndromes and things like that. What the question is, what do we know? What the sequelae are of not treating blood pressure in babies, and can we inform the normal range based on the sequelae rather than just on the 95th centile? It's probably an unanswerable question, and it may inform your relatively relaxed nature to sort of not treating some neonates that venture into, beyond discharge. But can you speak to that at all?
Yeah, I mean, I think it's one of those things where I wish I had the answer, right? Like, it would be great to have that data. I think the reality is that we don't know. I think the only patient population where we actually have good data about longitudinal or long-term outcomes is BPD babies or chronic lung disease babies. But the added factor there is thinking about, the babies that get followed closer are pulmonary hypertension babies. And, they're following those with echoes and looking at heart strain, which probably is a complicated metric given what we know about their lungs and pulmonary hypertension. So that is a very long way of saying I don't know. It would be great to know. I will say that a lot of times I see babies back we have a neonatal nephrology follow-up program. And we also have a nurse practitioner who follows babies in. So she is embedded in our NICU follow-up program. So she embeds herself and goes over and sees the babies who need to. And I would say 90% of the babies that we had kind of flagged as borderline high blood pressure are normal by the time they go home, or by the time they're kind of following up in clinic. I think some of that is measurement as well. I don't like it when someone puts an oscillometric cuff on my arm. I know better than to scream, but I'm not a baby. So I think that, we make a lot of assumptions about what elevated blood pressure tells us. And it may just tell us that a baby doesn't like getting their arm squeezed.
Thanks, Michelle. We just had another question in the chat from Alex Tran. So Alex says, for the 2-year outcome that shows elevated blood pressure in extremely low gestational age neonates, diastolic hypertension was twice as common. Does this have any clinical impact?
So I think it does. I classically think about diastolic being a better marker of underlying cardiovascular dysfunction. So when I'm evaluating anybody, whether it's a baby or not, if they have diastolic hypertension, I'm much more worried than if they have systolic hypertension. That's usually just my like general approach. I think some of this has to do with what they were measuring and how they were measuring. So these were trained study nurses who were measuring, truly measuring, with a very standardized, very rigorous research protocol. So I think it is probably more reflective of their underlying cardiovascular risk, and probably is even more concerning, right? If their systolic hypertension if it was flipped, I would be less worried. But 44% with diastolic hypertension, I think really speaks towards, a high risk of poor cardiac or, cardiovascular fitness during childhood and adulthood.
I've got one more question, if I don't think there's anything more on the chat. So you mentioned that you often get laughed at when you walk up into the NICU and suggest this is how you should be, the gold standard for measuring blood pressure. Again, it's a bit tongue in cheek, but I have a tendency to also laugh when I'm told that the cuff needs to be rotated among all of the limbs, to protect the baby from damage from the cuff. And that's probably not unreasonable either. What the question is there any reported consequence of over oscillometric measurement use on a child's limb if it's not rotated, and what sort of damage can be done, or can we relax that?
So, I mean, I think like anything, right? Like if you keep the cuff on and it's a preemie baby with really, tricky skin, right? Like, you certainly could probably do some damage. I think this is a place where there is a ton of need for innovation. So there is actually a device called the Bopley, which looks like, I should have brought one so I can show you guys, but it basically looks like a pulse ox measure. And it works by, instead of squeezing and getting the oscillometric, it basically senses and uses kind of similar technology to what we use to read SpO2. It has not been validated in hypertension. It is designed for evaluation of hypotension, but there are people currently doing studies to see if we can evaluate it as a better way of checking blood pressure in hypertension in babies. Because, man, wouldn't it be great if we truly felt comfortable in our blood pressure readings, and not felt like we're just reflecting a baby being mad at us. Awesome.
Thanks so much. We've drawn to the hour, so I think, and there are no other questions on the chat, but we're incredibly grateful for your time and expertise. I think just for those people that are still around, just to sort of re-echo the message to sign up for the NKC as well, it's probably worth mentioning that Michelle was one of the data entry personnel for the original Awaken study. She often mentions this actually when she speaks. So, and now, sort of, was it 10 years later, she's really, leading and pioneering some of the major initiatives for the NKC, including the Delphi guideline that was published recently and currently Awaken 2. And I think that really speaks to the NKC and its capacity for mentorship and sponsorship. So if that's a sort of group that you want to be part of, please sign up and come and join us.
Yeah, and I'm really excited. We've, had so many ANZ sites starting to come on board for Awaken 2. I think we just hit 14,000 babies entered today.
Wow.
It's just kind of incredible to see the spread. So we're really excited about that.
I also want to say a big thank you to Marissa, who currently has her video on, and to Heidi as well. I don't know if she's still here, but the Education Committee have been immensely helpful in helping us to set this up. And look after us from an IT point of view as well. So thank you to them. And Evelyn, did you have any other comments that you wanted to make before we closed out?
No, just really also thank you to Michelle. This was fantastic. It's the second time I've heard this talk and I keep learning things, so it's amazing. Thank you.
Yeah, of course. And I'm happy to share slides if I can send, I already sent them to you, but I'm happy for these to be circulated. Please use them to teach other people or to look or refer back to. So I'm happy to share.
Thank you. Heidi's just
And
turned her video on. Heidi, did you want to say something, or are you're just waving? Thanks very much. All right. Well, thank you, everybody. We'll close the inaugural Education Symposium for the ANZ NKC chapter there, and we look forward to your feedback and to let us know what else we can teach you, what you'd like to learn, and whether or not you felt this was useful. I certainly did. So thanks again, Michelle, and good evening.
all right. Thank you for the
Bye,
opportunity.
everyone.
Bye, guys.
And Merry Christmas to everyone.
Yes,
Hi, everybody.
indeed.
Nice to
Michelle.
see you all. Thanks for a great talk, Michelle.
Bye. Thanks, Michelle. Thanks, Marissa.